Hi everyone. Welcome to the Statistical Methods for Health Equity webinar series. My name is Awaz, and I'm a co-lead of this webinar series. This is a monthly series focusing on statistical and machine learning methods that have the potential to promote health equity. For example, methods that can shed a light on the complex factors underlying inequalities or fairer algorithms that appropriately take into account the biases that exist in data sets. This series is co-hosted by the Allen Turing Institute, specifically the Health Equity Interest Group, the UCL Statistical Science Department, and Data Science for Health Equity. Uh, Adishi is a global community of experts and enthusiasts working at the intersection of data science and health inequalities. Our aim is to ensure that the latest research and innovations in data science, machine learning, and AI improve everyone's health, and especially those in underserved populations. If this sounds like something you're interested in, then there are a few ways to get involved, which I will post in the chat very soon. Uh, Today, it's my a great pleasure to welcome Muhammad Ibrahim, and he is a researcher and an economist based in Pakistan, working with research and development solutions. And he has done a, a lot of work in producing local estimates for disease and access modeling, working in coordination with government partners to improve better decision making. And today he will be speaking on working on small area estimates, which I'm sure is very interesting to our audience here. And with that, I hand it over to Ibrahim, and and we'll continue the conversation in chat. The way that this a webinar will work is that I will have him present for maybe 25 to 30 minutes, and we'll open it up to questions. And yeah, this webinar is being recorded, and it will be put on YouTube. So over to you, Ibrahim.
Thank you very much. Thanks for the introduction as well. So I'll just repeat a few points. I'm working at Research and Development Solutions in Islamabad, Pakistan, and we're mostly working on small area estimations over here for different indicators. One of our work that I'm going to present is on contraceptive right now, which we have done using different sources available in Pakistan. So I'll share my screen. Um, So basically, I'm working with the knowledge management unit at RADS, and we do different kind of estimations using different national surveys and administrative data that we get from the ministry. This one is for contraceptive, and the idea came about because we did a lot of work before using the administrative data and separately for surveys, but there wasn't any survey that could tell us the information about the district level estimates of contraceptive prevalence rate. So this idea started from here, where we use the Bayesian modeling for our small area estimates. And so basically, contraceptive prevalence rate in Pakistan has been stagnant for over a decade, nearly 2 decades now, which has been 34%. And all the monitoring and other equipment have been focused mostly on provincial levels and national levels. So all the estimates that before the study were existing were present at the provincial level using different surveys, and administrative data isn't enough for computing these contraceptive prevalence rate for each district. So due to and these estimates are also missing because of smaller sample sizes available in surveys, which cannot be replicated for district to estimate these indicators. Um, Number of reasons. Another reason for that is the cost of household surveys that is very expensive. And as I said before, the administrative data isn't really capturing whether the consumer is using these contraceptives or not. They only have a data on dispensation of the commodities. So all of these uh, data sets provide us different contexts. And our goal was to use these data sets in creating a small area estimates. And here are a few examples of national surveys and administrative data of contraceptive in Pakistan. PSLM/HICE is a main survey which collects a lot of data of socioeconomic variables, but it has two versions. One is done at a provincial level where sample size is small, and it is a high quality with a lot of indicators in it. So it included contraceptive rate. However, when we shift towards the PSLM alone, which only is conducted on the district level with a larger sample size, that survey did not include any uh, section on the family planning indicators. Next is a famous survey, which is Demographic and Health Survey, which was conducted with a 5-year gap in Pakistan. That also had a smaller sample size, due to which district level representation wasn't possible. Lastly, there is CLMIS, which is Contraceptive Logistic Management Information System. Here we had the data on stock versus consumption that they call it. However, this is only dispensation according to many scholars, because we cannot assure whether the commodity that exited the facility was actually used by the consumer or user. So these data sets have their own positives that we tried to use for our small area estimation. This is one of our previous work where we started with district level estimations. This is more like analytical work, uh, in which you can see that in the y-axis, we tried to map out the stock per 100,000 marwa that was available in each district and compared it with the percentage of that stock that was consumed, dispensed. So we saw a discrepancy which is quite evident, like if we can see that this is the Punjab province, and in the Punjab province, there are higher stock levels available. However, consumption of those commodities are quite low. So we have published this article, and it's available on PLOS ONE journal, which anyone can access. However, these estimates were mostly produced with the CLMIS data, and these do not represent the contraceptive prevalence rate in each district. Hence, our study objective was to use the survey benchmarks from our PSLM, which is at the provincial level, use the administrative data as a signal for our dependent variable. Demographic data was also used for this, from where we extracted our MAVRAs, and socioeconomic covariates, which were correlated with the contraceptive prevalence rate, were used from PSLM, which is conducted at the district level. So using these sources, we estimated our district level estimates for 121 districts in Pakistan. This is again the overview. Provincial CPR and MCPR. MCPR is the modern contraceptive prevalence rate, benchmarks taken from PSLM, which was used in our first stage that I'm going to discuss later. Then CLMIS gives us commodities, specific contraception dispensation, which included condoms, pills, injections, IUDs, and implants. Census provided us with 15 to 49 married females data against each district. We needed this to normalize our CLMIS data, and our covariates, which were important to estimate to reduce the noise in each estimate, were taken from PSLM, which were education. Education was also an index, income index, fertility rate, which was important. Then agriculture and manufacturing share, employment share, which were important to assess the urban and rural areas in each district. So, as I said before, each estimation requires a dependent variable, and here we did not have a proper dependent variable for our estimation. So we divided our estimation in two stages. The first stage sort of took the information from different sources, and we created a dependent variable, which we called our crude district estimates. The reason why we called these crude district estimates was that as we did analytical work on it, and even though we did with this analytical work, there were possibility of being inflated estimates or underinflated estimates depending on the stocks. So to reduce the noise, the errors in our estimates, we in second stage use our Bayesian small area model with the covariates that we had from the district level survey. This is a flow chart, the way we used our estimates, starting with the CLMIs, PSLM 1819, and the census were used in the first stage. And we got two estimates from our first stage that were used in the Bayesian model. Our covariates go straight into the second stage, where we use them as dependent variables for our model. So moving on to the first stage, from the CLMIs, we had the commodities. And for the contraceptives that are used in each way are calculated by the couple years protection. So each commodity has its own couple years of protection. We multiplied those to get users for each annual year, and then divided those couple years of protection by MAVRA to get this district level estimate. Then we also produced a provincial estimate, and then against that mean value of provincial estimate, we calculated the deviation. That deviation gave us a signal of from how much a district estimate deviates from a provincial, and we multiplied that deviation against our CPR rates from the national survey that the provincial survey estimates, and got each estimate a crude estimate of our dependent variable. CPR and an MCPR were created as crude estimates with this strategy, obviously having the noise and error in the estimates. And then we also incorporated the standard errors of the survey into the model, which were uh, used to give a proper signal like how much standard error each estimate will have during the estimation. Now, the second stage included our model in which we basically had proportions for each district. So our model was used against the logit family, where probabilities of contraceptive prevalence were calculated using the covariates as suggested before, and provincial effects were modeled jointly for CPR and MCPR. So the covariates were similar for the both models, and the provincial effects were modeled jointly to create a bivariate model. As CPR, overall CPR includes the traditional contraceptive methods, and MCPR is only the modern contraceptive methods. So both and CPR cannot be higher than modern contraceptive prevalence rates. So to adjust for that, we used a bivariate model of Bayesian model in our estimation. So two additional parts were used where we in the first stage, when we calculated our CPR rates for each district, the crude estimates, there were few estimates that were more than one, uh, which cannot be true in reality. So those were treated as outliers, and to adjust for their elasticity in the model, we used our users divided by Mavra as a normalized estimate to get the signal into the model, what the estimation in the posterior estimates that we were going to get will have a trend like. So that we used users per Mavra as a estimate to signal the model what kind of relationships can be built for the posterior estimates where we do not have the dependent variable in the model. Secondly, our provincial estimates were acting as anchoring for each province. So from the national survey, which is acknowledged as a good survey in Pakistan, uh, which provides us with provincial estimates, we use those estimates as a benchmark in our model where each province anchored with its own CPR rate and a modern contraceptive prevalence rate. So, as I said before, MCPR has to be lower than CPR as it only includes the modern contraceptive prevalence uh, in the district. So, we added an additional check in the model that none of the estimates of modern CPR exceeds the contraceptive prevalence rate when the estimations are done. So, that was important. And sorry. Another important thing that is the proxy model parameters in the Bayesian estimation was that rural areas where occupation of agriculture is more, there is high probability of uh, not reporting the at the facilities. So we included that in our model, and industrial is more like in an urban area where reporting rate will be higher. So those errors were also incorporated in the model for better estimation of our contraceptive prevalence rate. And our covariates mentioned on the left side, uh, education, income, and fertility, these relationships were given as a prior information in the model, which were higher for the contraceptive prevalence rate, as it includes two kind of methods, which is traditional and modern. And modern CPR included lesser kind of relationship. The magnitude of these relationships were gathered from the literature. Education and income has a moderate effect on the contraceptive prevalence rate. Agriculture share of, you can say that it has a much negative impact on contraceptive prevalence rate. In rural areas, there will be lower contraceptive prevalence rate compared to the in urban areas. And lastly, fertility is a direct inverse relationship with the contraceptive. So we had a higher value for this relationship as a prior information in our model. So final outcome came out as a CPR and MCPR prevalence with their confidence intervals. All of the districts provided were giving us MCPR lower than CPR, which was as expected. We did few of the checks internally. Confidence interval is something that I'm going to discuss later. Then interval ordering was checked, provinces that have higher CPR. Punjab was the one which had the higher CPR, and the lowest was Balochistan. So that ranking was followed in our model. And the relationship that we got for the sectoral correlations was as expected. Agriculture was negative, meaning that rural areas were having a negative relationship with the contraceptive prevalence rate, and urban areas had the positive correlation. And we also did an external checks where we computed our estimates at the provincial level to see how much deviation was there compared to the national survey that was done at a provincial level. Our model sort of converged properly. All of our indicators showed that there was that the effective sample size collection showed a good correlation with our estimations. And we didn't see any divergence in our estimation, so that was also positive. And our Bayesian fraction of missing information was higher than the recommended threshold, which meant that the posterior estimations that we will do would be much cleaner after our training of the model. This graph shows our estimations of the cruise estimates, the variation between the two. We can see that the model for Balochistan, which showed lower estimations for the district, were due to probably not stockouts or the lower reporting rates. Could be a possibility for many districts. So those estimations were brought up to a level where provincial estimation anchoring was properly fitted. Then KP, again, Punjab and Sindh were corrected. When the Bayesian model, the noise was reduced and the variation that we see in the model was properly adjusted using our covariates, the signal that we were getting from them, the signal that we were getting from the proxy model of adjusting the facility level errors, and then the anchoring that was provided by the provincial estimates. Next is the confidence internal validity was quite positive. Our median percentage points of confidence interval was 6.8, and for CPR, for MCPR, it was 5. The range was less than 20 percentage points, which is acceptable in international journals. And for each province, we can see a variation for the confidence intervals. Secondly, we estimated, as a second check, we multiplied all the contraceptive prevalence rate and modern contraceptive prevalence rate with the MAVRA, and then summed it up to the provincial level to see whether our estimates show similar contraceptive prevalence rate against our PSLM CPR. So the percentage points difference was within 1 percentage point in absolute terms, which is a positive sign that the model was using all the information properly. As a second check, we did an external validation where we referred to the literature that was already available. The first 12 cases or the estimates we got for the districts were within 5 years of range of the survey that we're conducting. So we were basically looking at 2020 contraceptive prevalence rate, and these surveys were within that five plus or minus range. So the estimates were more or less very near to what the literature told us for many districts, except for a few, where we can see that the percentage points difference was more than 5%, which includes Mardan, Khushab, and Sialkot and Quetta. So other than that, most of the literature showed a similar kind of a contraceptive prevalence rate for each district. Second, last three are the districts that we didn't get any recent literature where we could verify our results. So, however, we included those because those were important to show that the contraceptive prevalence rate has been similar in last for these districts. Seems like it was a similar estimate in last 1.5 decade. Uh, Here we represent our results. Basically, Punjab is the mostly urban province, whereas north side of Punjab, which is uh, underneath the Islamabad and then ends at the Rajanpur and Rahim Yar Khan district. These show that the contraceptive prevalence rate has been higher for the districts which are up north or in central Punjab. And as we go downwards, the contraceptive prevalence rate is quite lower, which is similar to what we assessed in our previous study that I've shown in the start. Uh, that south has fewer stock levels, and here we can see that that reflects into the contraceptive prevalence rate that CPR is lower at the south side compared to the central and north side of Punjab. Then another important finding is that districts of KP, which are near to Punjab province, had higher contraceptive prevalence rate compared only to Chitral, which also has higher CPR. However, the districts which are closer to Afghanistan, um, that we can see over here, have lower contraceptive prevalence rate. This is also an indication that this was an area which was a tribal area before, and it was recently in 2017-18 merged into KP province. And if we go into Sindh, we can see that there are two major urban areas, which is the Karachi, zoomed in the graph, along with Hyderabad, which is in the mid of Sindh province. The CPR rates are higher, and the other districts of the Sindh province have a lower CPR compared to these two districts. And if we see Balochistan, which is southwest of the graph, it kind of shows us that the contraceptive prevalence rate are quite low, and something that we've seen in the provincial survey as well, that the contraceptive prevalence was lower. Balochistan had a lower CPR rate compared to other provinces. So, however, there is a variation. Like we can see that Quetta is the capital of Balochistan province. It has a higher CPR rate, as well as Gwadar, which has a coastal port as well. So these are better performing districts compared to other districts in the province. Similar trends were seen for the modern contraceptive prevalence in the country. Same as Punjab has a spillover effect into KP districts. And then we can see that the south of Sindh has a lower CPR compared to other districts. It was similar to our finding in the previous study, like these districts had lower stocks of commodities of contraceptive, hence their CPR rates are expected to be low. So, in conclusion, these small area estimations were important as in a previous study, we did show a variation in each district. However, those estimations do not show a real indicator that can be quoted as something for each district. These estimations provided filled those gaps, and now we have the data that can tell which district is lagging behind from which district, and these estimations kind of have more used for the policymakers to know where to intervene in which areas they should intervene, and this is mostly to optimize their supply chain and increase the outreach planning that they should do in the remote areas. And we are taking this work into other indicators as well. We have also estimated a life expectancy in Pakistan using machine learning models. And using other indicators as well, so that the policy making is much more is at a level of is at a granular level in Pakistan using these estimation techniques. So that's it. Thank you.
Thank you so much, Ibrahim, for your presentations. And now we can open up to questions, and probably I can start off by asking you, what motivated your choice of methods here? Because after seeing your presentation, it was very reminiscent to me of the, for example, a global burden of diseases approach, where they get different estimates, they do anchoring and so on and so forth. So can you just give us a bit of your thought process behind this?
Yes, so we have been working with the Institute of Health Matrix and Evaluation, who has done a lot of global burden of disease, and we got most of these ideas from them. So our approach has been that a lot of the districts that are neglected in the country, they have very poor indicators of health, and those need to be highlighted. And some of the areas are not approached properly using the national surveys, and the district uh, level administrative data always has some noise in the data. So we to properly estimate those things, we wanted to combine all the data that was available, because the policymakers always infer that their data is much better than the national survey data, and there has been a conflict in that. So we all wanted to combine all of these sources and present these estimates which can be acceptable by each policymaker in the country.
All right. We have a question from Tabassum. Can you please unmute and ask?
Yeah. Thank you, Usman, for this. Sorry, Ibrahim, for this presentation. Uh, yeah. So I have two questions. Like one is related to methodology which you used, and one is related to the findings. So for the methodology, I just wanted to I'm not really aware of the Bayesian modeling and these estimations. So I just want to know, are there any specific assumptions which are needed to hold in order to get the credible estimates from this specific methodology which you used? And if there are, what are those? And how did you ensure that those assumptions hold in your case? So this is methodology related question. And the other one is related to the findings. And so, like, are there any like surprising findings you have, like, like in context of because I think we all understand that urban areas uh, have better because of more awareness and because of all this, it should have better CPR level as compared to the rural areas. So I'm just interested to know if are you like, is there any a specific finding which you found very fascinating and something which you can carry forward? Yeah.
Yeah, thank you for your question. So basically, Bayesian modeling is a hierarchical technique where it has a lot of advantages. One of the advantages is using different data sources, and most important source comes in as a covariates in the model. It Important things are like the data that you have is not really has doesn't have a lot of errors already in it. So as we use a lot of standard errors within our model, those the standard deviation or the standard error shouldn't be that broad. Hence, your estimates will sort of explode within the model. So to contain that, have much better data that is reliable enough. And if it's not reliable enough, then it's better not to use it. The, because Bayesian has its advantage as we used anchoring variables within our model, and those were giving enough signals to the each estimate of the district. It also was providing the you call it the random effects in the model. So these random effects sort of also give additional signal to the estimate for correcting the noise in the estimate. The advantages of Bayesian modeling are a lot. Uh, when approaching this model, I think it's important to also have some kind of correlations like we had with the fertility rate and the urban and rural divide. And obviously, education and income always goes along with these covariates. These signals are always important to have at the level that you're trying to estimate your model. Your second question was the interesting finding. So technically, as expected, like we do see Quetta as uh, a really basically the most urban area of Balochistan. It was expected that the contraceptive prevalence rate would be higher than 20. However, it wasn't higher than 20 there, as suggested even by the literature, which one of the literature shows that the contraceptive prevalence rate was 30% over there in past few years back. So that was interesting. Like Balochistan is something that has contraceptive prevalence rate completely low even for the urban areas, and there is a huge gap between the districts of Punjab and Balochistan. Another important finding is obviously Chitral, which has a higher, which is sort of has a border with Afghanistan, China, and Gilgit-Baltistan, and accessibility is not that well. And we see that in KP, the outperforming district has been Chitral, Upper Chitral, and Lower Chitral, and that's something interesting. Another interesting fact from the literature that we had was a lot of surveys have been, or a lot of intervention has been done in districts of Badin and adjacent to districts to Badin. However, their contraceptive prevalence rate has been quoted as higher than 30%. But our estimates kind of show that according to the existing data, those estimates are not higher than 30. Rather, these are below to 25%. So we can see the different discrepancy compared to what literature tells us, where surveys are happening at a district level or by different private organizations or non-government organizations, and the data sort of tells us different story for those districts. I hope that answers the question.
Yeah.
Yeah. We have a question in the chat about, I mean, if there were any alternative strategies that you were choosing. And I guess, I mean, from the discussion so far, I mean, you can, take as many data sources as you want, right? To update the estimates, and that could include the governments, or if there's an NGO working in the area, their own data as well. So how would you evaluate um, an additional a data source to incorporate in your estimates? And then the question in the chat, where I mean, if you were considering any other methods as well, in addition to the Bayesian method.
So data sources are obviously, if data sources are credible enough with fewer errors, like I said before, then it's usable. And then additionally, I think important thing is always the additional variables which are not similar to these variables, if they have any correlation with our dependent variable, those are important. And if those are accessible enough so to be used in the model, then those variables should be used, obviously. The more uh, backed more variables that you have, which are backed by the literature, which kind of shows a correlation between your dependent variable, those are important. You obviously cannot have any kind of variables which doesn't have any association with your dependent variable in the model. We selected Bayesian due to its, I think it would be appropriate to say that the flexibility that it provides. We have the possibility of giving it the prior information, where we can say what a kind of correlation each variable has with the dependent variable, which is backed by the literature. And that flexibility is not provided by other models that we have used similar to for our small area estimations. And Bayesian sort of provides that within the model. And obviously, literature-backed correlations are more important, and it kind of adjusts the noise according to those information that we provide the model. This is one of the advantages. Then other advantages, having the hierarchical variables in the model that I've discussed before, that you have provincial estimates which are giving information to each district what kind of final result should look like. So these are the two advantages that due to which we used Bayesian model. And I think these two are the main reasons why we use the Bayesian model for our estimation.
Thank you. And I mean, we have people here on this webinar who may have done similar work in other parts of the world. So if anyone has uh, examples that they would want to share, I mean, we would welcome that, because I think, I mean, in a resource as a constrained environment. I mean, these low cost strategies are very, very valuable. Um, so yeah, I mean, feel free to share in the chat, or to speak. And yeah, while we do that, I mean, what would be the next steps for your methods and analysis? Like, I do think it's transportable to other things. estimating other stuff, locally, or do you see broader applications of your method as well?
I guess there are different uh, concepts that we can see. If we see how IHME is doing it, they are creating indicators for uh, countries where even if they're not getting any data from each country, even then they're using the spatial correlation and the temporal variation within the data to create estimates for those countries as well, from where you're not getting any data. So similar context in Pakistan is there, like even if districts which are not accessible in terms of getting the data from, those estimates we can create using these methodologies. And this is a important point that we have used for our next research, where in Pakistan there isn't enough data that's coming out of Gilgit-Baltistan and Jammu and Azad Kashmir. So we're trying to use in the next way as a next step, trying to estimate the contraceptive prevalence rate for these uh, districts in those two federal areas. Another uh, important thing is to include the temporal effects and the spatial effects within the model that we have tried, worked, and finalized, sort of, uh, but still trying to validate our estimates. Uh, Other indicators that are important in terms of Pakistan, like we have seen that the global data sort of shows that in Pakistan, the cardiovascular diseases uh, are causing more deaths in the recent years. So we're trying to estimate and the uh, for these indicators such as hypertension and diabetes as well. And we, like I said before, we have already done an estimation for life expectancy using a machine learning model, which is uh, using the data from the at the global level and then bringing it down, training it on the global data and coming down at the district level for us. So we another important research that we're trying to do is to calculate the population estimates uh, at a much granular level, which will be at a 1,000 square foot square kilometer square or 100 meter square, possibly, which are important for much more granularity of data that can be used for policymakers, which has much more uh, importance for the to be used in the emergency response and related situations where you need to know what kind of where are the populations dispersed across the country.
Thank you so much. And yeah, just I want to check if anyone from the audience has any outstanding questions that we can answer. You can unmute yourself. All right then. Yeah. Thank you so much, Ibrahim, and your team for doing this work. I think it's very important, and we are uh, hoping to highlight more examples of this kind of work from LMICs in data science for health equity. So I mentioned the social media and Slack channels in the chat. Be sure to go to them, be a part of our community, and we I look forward to continuing this conversation. So thank you to everyone who joined us, and we look forward to seeing you at our other webinars and our other activities. Thank you so much, and I hope you all have a great day. Bye.